Great, so welcome everybody. My name's Reagan Dunham. I use she, her, hers pronouns, and I am the Health Equity Manager with the Washington AIDS Partnership. And we are really excited to put this training on for y'all. It's something that I have been curious about for a really long time. And when I talk to different providers here in the DC area, I find out a lot about providers who are providing reproductive justice services for folks who use substances and aren't really sure what to do, and also harm reductionists who have pregnant clients and aren't really sure what to do. So I think that this is really just going to be a great opportunity for us to learn, for me as well to learn from the Academy of Perinatal Harm Reduction and Joelle's wealth of knowledge. I'll give a little bit of background about, I guess, myself and the partnership. So I'm currently in Southfield, Michigan, but I'm based in DC, where the partnership has existed since 1988. It was founded during the height of the AIDS epidemic to really channel resources and funding into on-the-ground services. And since then, we've been working to support different HIV-focused organizations in the area, and I've seen some staff members from some of those orgs here. So I'm very excited to be with you all today, and I'm going to pass it to Joelle.
Hi, everybody. Welcome, and thanks for putting up with our technical difficulties. We'll get this figured out. I am just going to kind of dive right in because we have a lot to go over today. So we'll get started. My email is there on the screen. It will also be available in the slides, which are going to be emailed to you all tomorrow, as well as everyone else who registered with the recording. So please feel free to reach out to me anytime. I love corresponding with people, and I say that every presentation I give, and nobody ever writes to me. So give me your questions, give me your criticisms. I want to hear it all. Let me get to, there we go. So my name is Joelle. My pronouns are they, them. I've been working in NICU and postpartum for almost 15 years. I'm a travel nurse, so I've worked in 14 hospitals in 8 states. And I really wanted to do that both because traveling is awesome, but also because I wanted to see how this population is treated in different geographical areas, and even in different hospitals within the same geographical area, there are vast differences. And we'll talk a little bit more about that a little bit later. I've been a presenter at all kinds of very fancy conferences. I'm super excited to be here with Reagan and Washington AIDS Partnership. I'm one of the 3 co-founders of the Academy of Perinatal Harm Reduction, and you can check out our website. We have tons and tons of free information, infographics, posters, pamphlets, flyers, all kinds of good stuff. Please feel free to take and use and share anything that you find on our website. Our mission at APHR is to improve the lives of pregnant and parenting people who use substances. We want to create communities where families are safe, intact, and informed, regardless of what they put into their bodies. We don't think that should be a reason in and of itself to keep people, to take families apart. I don't have any relevant financial relationships. If you'd like to have a financial relationship with me, hit me up. Before we begin, I want to do an Indigenous acknowledgement. I chose the Piscataway people because of Washington AIDS Partnership being based in Washington, DC. They are also known as Piscataway. And when I spoke to Natalie standing on the Rock Proctor a couple years ago when I spoke in the area, she said she's fine with either. I kind of summarized our conversation here. Natalie said that she stopped accepting invitations to events because she felt like it was just tokenism and people just wanted to use her to check off a box and kind of, you know, do that performative activism and prove how good they're doing. But they didn't really want to do anything for real change. They used to have a museum and cultural center, but that had to close because they didn't have enough people in attendance. They also, since I made this slide, have stopped doing the Living the American Indian Experience program, partly because of lack of interest and partly because they kept being asked to avoid certain truths about our history with the Indigenous people of this land in order to make non-Indigenous people feel more comfortable. And that's not cool either. She said one of the things that she feels the most and she hears from her people the most often is that they're just perceived as invisible. And people, especially on the East Coast, think that the Native people were completely eliminated and are no longer around. She also said that people just they want to see certain parts of history. They want to see, farming and working the land. They don't want to see Native people working in computers or design or the film industry. And it's kind of like she feels that people want them to be stuck in history, but only a pretty kind of history, not the actual history that actually happened. I would love to encourage each one of you to make a small donation today, please. You can use PayPal at piscatawayindians@gmail.com. If each one of us gives $5, that would be $500. So that would be really magnificent if we could do that. So please consider donating piscatawayindians@gmail.com. So with that, we will dive right in. What we know about people who use substances in pregnancy and parenting is not the whole picture. I want to talk a little bit about how knowledge is created before we dive into what the evidence actually says. So study samples in all of the studies that are done in the United States and Europe are not representative of the general population and cannot be applied to the general population. We're studying people who get caught. So that's a particularly oppressed segment of the population. We're talking about people who are marginalized because of race, because of marital status, youth, ability, LGBT status, and these are also folks who have, based on their oppressions, they have higher risks. People who experience racism have higher stress, higher cortisol levels, which can have effects on pregnancy outcomes. People who are caught up in systems of control and never feel like they can relax, even in their own homes, because of drop-in visits and surveillance. Those types of folks are going to have negative outcomes compared to the general population already. And a lot of studies do not take that into account at all. When you're reading this kind of research, you need to be looking for, is the control group comparable to the group with exposure? Did they control for poverty, nutrition, income, and things like that? So it's really important to keep in mind when we're looking at a lot of this research. We also see that the people who fund and design studies are not interested in looking at the whole picture. You can see it right there in their name. We have the National Institutes of Drug Abuse. It's not the National Institutes of Substance Studies or Drug Studies. They're specifically looking for negative outcomes, and they won't fund your study if you don't find them. There have been lots and lots of studies that have struggled to find funding and publishing because they report on their outcomes accurately. So what we end up with is the stuff that does get published, the stuff that makes it into our journals, which inform our public health messaging, is kind of a twisted vision of reality, where these authors will have their data, but they're forced to analyze their data and reach conclusions in such a way as to find negative outcomes. We'll see that a lot. There'll be, some study of birth weight or something, and like all the babies are within the normal range. But in the conclusion, which I suspect that a lot of researchers just read the abstract and the conclusion and skip all the parts in the middle, because a lot of stuff is cited inaccurately in this manner too. In the conclusion, they'll be like, we found a significant decrease in birth weight based on blah, blah, blah exposure. But then if you go and look at their data tables, they absolutely did not find that. But in order to get published and funded, they had to. So we need a little bit more courage from our researchers and our publishers. So the result of all this is phrases like this coming from our most respected organizations, like the American Academy of Pediatrics. This is from a 2013 paper by Mary Lou Banky and Vincent Smith. And I'm going to read it once, and I just want to see if you can point out what's wrong with this. They say these altered behaviors, which include poor nutrition, decreased access to or compliance with healthcare, increased exposure to violence, and increased risk of mental illness and infection, may place the fetus at risk. So we're talking about poor nutrition, decreased access to healthcare, increased exposure to violence, and increased risk of mental illness and infection. Are any of those behaviors? No, none of those are behaviors. All of those are vulnerabilities. And yet this made it through countless committees. This was published in Pediatrics, which is one of the most prestigious journals in the United States. And I'm going to be completely honest with you guys. I read this probably 4 or 5 times before I even noticed it, because we're so accustomed to blaming pregnant people for their own vulnerabilities. We know that blaming the victim is no good in other areas, but for some reason, when people use substances, we're okay with it, and it just goes right over our heads. They allowed this paper to expire without renewing it, by the way. So that's something, but not great, because now hospitals are just left with this, and they don't have something new or better to use. And this particular paper has been used by multiple hospitals as an argument for why we can't provide compassionate evidence-based care for our patients, in arguments with yours truly. So I would have much preferred that they made a new one rather than just letting it expire and pretending to just, brush it under the rug. So we're going to talk very briefly about 2 ideas in research. The first one is association versus causation. When we're talking about harm reduction for people who use substances in pregnancy, we're not really talking about reducing harms associated with drugs very much. Very, very little of what we're doing has to do with the actual drugs. Most of what we're doing has to do with our society's response to people who use drugs, and especially people who use drugs in pregnancy. So you see surrounding the person in the graphic, we've got some handcuffs, we have some environmental pollution, we have some housing insecurity, we have some nutrition problems, we have poverty. These are all completely unrelated to substance use. These are related to the way that our society punishes, isolates, and ostracizes people who use substances. We're not trying to create a system in which people are able to thrive. We are actively trying to punish them and force bad outcomes out of some misguided idea that punishment has ever been an agent of positive change, which it has not. So one way to think about this idea is if aliens came down from another planet and they were trying to study humans and our environment and figure out how things work down here, they might notice that every time people pointed umbrellas up towards the sky, water fell down. So they may come to the conclusion that umbrellas cause rain. But really, these 2 things are just found next to each other, and their relationship is much closer to rain causing umbrellas. And this kind of thing can happen in drug research all the time. We look at people who use substances and we see that the ones that we're studying oftentimes tend to have issues with poverty and nutrition, etc. So we think, oh, they take drugs and therefore they're poor. But oftentimes it's completely the opposite. People use substances because of poverty and because of desperation and because of not having options in their lives. So it's really, really important to keep an eye on the researchers when they're describing the nature of the relationship between two things. The next concept I want to talk about is the difference between statistical significance and clinical significance. Statistical significance is the idea that the result you got in a study is unlikely to be because of chance. So in order to get a result that's statistically significant, you have to have a very large study population. So what we're talking about is, like, let's say you wanted to do a study of eye color in the world, and you grab 5 people. All of them have brown eyes. So you could reach the conclusion that everybody in the world has brown eyes. But because your sample is so small, your data is not statistically significant. If you do a study of 50,000 people, you're going to get still mostly brown eyes, but you're also going to get some blue, some green, some hazel, and your result is going to be much more likely to match the real world and not just to be the result of chance. So that's kind of the difference between statistically insignificant and statistically significant results. When we're talking about statistical significance versus clinical significance, we're talking about, so not just do the numbers make sense. Clinical significance means, does this actually matter to the person? So like I was saying with birth weights earlier, when you're looking at a study group where all the babies are between 3 and 4 kilos, but this subgroup maybe is smaller on average by 50 grams or about 1.5 ounces. That may be statistically significant if you have a large enough study sample, but it doesn't really matter. Nobody cares if your baby is 7 pounds 10 or 7 pounds 12. Like, they're both a good size and they're both healthy and normal. So what we see oftentimes is researchers in their conclusions saying, we found a significantly decreased birth weight for babies exposed to X substance. And they're technically telling the truth, but it's also disingenuous because they know that journalists and other people who are not keeping a razor eye out for those differences in language are going to miss that, and they're going to interpret that significance as, what most of us think of significant, meaningful, something that matters, when in reality, it's really not. It's just statistically significant. So with all that, now we get into the substances. We're going to focus on alcohol, opioids, and cigarette smoking and tobacco, because that is what you all told Reagan that you were most interested in. At the end, if we have time, I do have a little bit to say about cannabis and stimulants as well, but we'll focus on those big 3 first. So alcohol, out of all the substances that I talk about, is the number one, easily and by far most harmful, both by numbers, severity of harms, no matter which way you look at it. Fetal alcohol spectrum disorder prevalence in the United States is estimated to be about 2 to 5% of all babies. So that is up to 1 in 20 babies affected by alcohol exposure. And I think a lot of this is due to the way our country handles public health information about substances. Excuse me. Because we have been lying to people so blatantly and for so long, when you see that pregnancy warning on your can of beer or your bottle of wine, you're just like, oh, this is probably lies too. It's not as bad as they say it is. And so we end up with a culture in which drinking during pregnancy is normalized. And I don't want to shame anybody for drinking during pregnancy. That's not what I'm trying to say. But what I do want to say is, I don't know anybody who didn't drink at least a little bit during their pregnancy, despite the really strong scientific data we have that there is no safe level of alcohol consumption during pregnancy or lactation. So we're going to talk a little bit more about infant effects on the next slide. We also see with alcohol consumption increased rates of miscarriage and stillbirth and impaired placenta function. Now, for those that need a little review, the placenta is the organ that it's a brand new organ. It forms with each new pregnancy, and it's kind of the go-between for the pregnant person and the fetus. So pregnant person blood comes in and swirls around, it drops off nutrition, and it picks up waste products. And that is how the fetus is fed and grows and gets rid of waste. And so if we have impaired placenta function, we end up with the fetus either not getting enough nutrition and being kind of small, or we end up with deficiencies in certain elements of nutrition, which can be quite serious, especially if we're talking about like B vitamins, for example, which are essential for healthy brain and spinal cord growth. So fetal alcohol spectrum disorder, or FASD, it used to be known as fetal alcohol syndrome, but we've changed the name both because the word syndrome is kind of stigmatizing, and also it suggests that there is one outcome, whereas a spectrum disorder lets you know that there's a wide range of outcomes from very mild to very severe. The primary diagnostic tool for FASD is the dysmorphic facial features. So we see kind of a flat bridge of the nose right here, and then this little wrinkle between your nose and your mouth will be smooth in the baby when they're born. We also see smaller heads, smaller chins, and a little bit of extra skin folds around the eye. Now, these facial features, they go away by the time the child hits puberty, and they're no longer quite so prominent. But what doesn't fade by puberty is the behavior, cognitive, and motor effects, and those are permanent. We don't have any treatment that's able to reverse the effects of FASD, so all of our treatments are supportive. So this means helping people with dyslexia, attention problems, giving them, assistive reading tech and things like that. We think that any decrease in the amount of drinking is going to help. So it's never too late to decrease your drinking anytime during pregnancy or the lactation period. But we also see that there's not a dose-dependent relationship with how much you drink and whether or not your child is going to have effects when we look at multiple different people in studies. And that's something that I'm really interested in. Every couple years, I go back to the literature and try to see if anybody's found anything about that, and they haven't. Last time I looked was about 6 or 9 months ago, and there are always a handful of new studies looking at this, trying to find that dose-dependent relationship between alcohol and infant effects, and they just haven't been able to find it. So this makes me think that either there is a particular time during pregnancy during which the fetus is more or less vulnerable to the exposure. There may be a certain genetic component, certain folks being more vulnerable than others. Or what I suspect is the case is that it's alcohol plus something. It's alcohol plus an environmental contaminant or some other exposure or a certain level of stress hormones like cortisol. But the answer is we don't know. So the safest advice to give people around alcohol and substance exposure is to stop doing it. So if I have somebody that's using heroin, meth, cigarettes, and alcohol, and they ask me what should be my priority, alcohol, easily alcohol. Alcohol should be your priority to cut down. So with opioids, the effect that most people are hearing about these days is neonatal opioid withdrawal. It used to be known as neonatal abstinence syndrome, but we're using this new terminology for a couple reasons. Firstly, that word syndrome. It is very stigmatizing, and it also suggests a condition that is permanent, which opioid withdrawal is not. Babies tend to spend, depending on how they're treated, a few days to weeks withdrawing, and then afterwards, their outcomes are similar to their peer groups. They just need the same supports as any other baby. The other reason that we've changed the terminology is because neonatal abstinence syndrome, as identified in 1971, I believe, by Dr. Loretta Finnegan, only applies to withdrawal from opioids. It is not applicable to stimulants like cocaine or meth. It is not applicable to alcohol. It is specific to opioids. And when we have a condition that is specific to opioids and we don't name it as such, we end up with situations like I've seen where infants who were exposed only to stimulants are given an opioid dependence in the hospital because providers, doctors and nurse practitioners don't understand the condition that used to be called neonatal abstinence syndrome. I personally took care of a baby that had only been exposed to cocaine. Mom said she only used cocaine. She only tested positive for cocaine. Baby only tested positive for cocaine. We, for some reason, started giving that baby morphine, which developed into a dependence. If you're given morphine every 3 hours for a week, you're going to have a dependence. And then that baby ended up staying in the hospital for like a month and a half based on a condition that we created. So this can cause serious harm, and we need to make sure that our language is precise. Again, with opioids as well as alcohol, we don't see a dose-dependent relationship when we're looking at large groups of folks. Somebody who's taking a small dose of methadone, like 50 milligrams, might have a baby with much severe and longer lasting withdrawal than somebody who takes a much larger dose. I think that a lot of this has to do with the way these babies are treated. And in reading the research and also in working at different hospitals all over the country, I've seen that the way babies are treated has a huge effect on their outcomes. For example, if you have a baby who is being treated in an open bay NICU with 6 or 10 other babies in there, lights on all the time, monitors going off, different people in and out, different smells, different sounds, and an environment that really doesn't make it comfortable for their parent and their family to come in and stay and hold all the time and breastfeed and do all the things that we know help, then that baby's going to require a higher dose of morphine and they're going to stay longer. But if we have babies in a private room where there is space for their family to stay and to hold and to breastfeed and chest feed, where we have refrigerators for families to store food, where we have showers for them so they don't have to leave and go home, those babies do so much better. The babies that don't require medication for their withdrawal are always the babies whose parents are enabled and empowered to spend a lot of time with them. I just recently heard from a colleague about a baby who was in the hospital for 5 days, which is the recommendation, didn't require medication, but then because of punitive and not non-evidence-based child welfare laws, that baby was taken from her family and given to a foster family. Immediately, when she went to the foster home, she started having severe withdrawals, couldn't eat, couldn't sleep, and the foster family was confused and was calling the hospital, like, what's going on with my baby? And what happened was, if you take a baby away from the one thing in the world that baby wants, which is its mommy or its parent, that baby is going to be upset. And we're going to see those withdrawal symptoms come back because we know that the number one best treatment for neonatal opioid withdrawal is parents, is holding, is cuddling, is smelling their mommy and listening to their heartbeat. And that's not just like something I'm saying, that we have lots and lots of data to back that up. So when we have this wildly disparate methods of treatment for these kids, it's really hard to look at the research and get any meaningful kind of conclusions from that. Because was this withdrawal more severe than that one because of the substances, or was it the context? And most of the time, I'm betting it's the context. Like I said before, once they're done withdrawing, they're done. Long-term outcomes are similar to the peer group. And oftentimes you'll hear claims that long-term outcomes are negative, but that's again a problem of not comparing these groups to a similar control group. When we're looking at people who get caught and people who maybe live in poverty with poor nutrition, maybe only one adult in the home, and then we compare them to the general population, that's not an accurate comparison group. So it's really important to check your comparison groups. When we do that, we find the outcomes are the same. People often ask me what to do about opioid overdose in pregnancy, and I think this question comes from a place of our former understanding, which was that if somebody goes into withdrawal during pregnancy, it can put so much stress on the pregnancy that it results in miscarriage or stillbirth, which we do know that it puts stress on the pregnancy, but we're having some emerging data and emerging studies lately that show that a gradual withdrawal can be safe. It's recommended to do it in the second trimester if possible. We see more risk of miscarriage in the first trimester and more risk of preterm labor in the third trimester. So we know that it does put stress on babies, and it is absolutely not recommended as a first-line treatment. But if your client is very motivated and that's what they choose after a thorough risk-benefit discussion, then it can be accomplished with reasonable safety. So for overdose in pregnancy, you need to respond the same way you would for anybody. Naloxone, rescue breathing, supplemental oxygen if you have access to it. Oftentimes, we can reverse an overdose without even using naloxone if you have supplemental oxygen and, like a bag and mask breathing device. And I think that for everybody, not just pregnant people, we should try to use the smallest amount of naloxone possible to get them breathing again. People don't have to be thrown into precipitated withdrawal in order to save their life and reverse the overdose. We just have to get them breathing again. So there's a lot of new naloxone products on the market that are very large doses. And I get the thought process behind that. I've heard people defend these products saying that they're designed for use for people who don't have an opioid habit, so will not be put into withdrawal no matter how much naloxone you give them. And I say, okay, that's fine, but like, you can't tell when you come upon somebody who's overdosing whether they have a habit or not. You can't tell just by looking at them. And so if we're giving people these giant doses of naloxone, yes, their life is saved, but also why do we feel like it's okay to punish them with that pain and that sickness right when they wake up, when they're already disoriented? Most naloxone kits that are given out in the community contain 2+ doses. So if you do need that extra dose, it's there. But I think in all of medication and all of medicine, we're taught start low and go slow. You don't need to start with a gigantic dose. Start with a small dose, continue giving them rescue breathing, and see how they go. And that should be applied to people who are pregnant and everyone. The one thing that we can do differently in pregnant people versus non-pregnant people is after they start breathing again and you place them in recovery position, put them on their left side, because that's the side that's going to increase blood flow to the uterus and help the baby recover faster. So our gold standard in pregnancy and otherwise is methadone and buprenorphine. These are the treatments that we know work. And when I'm talking about treatments working, they keep people from dying. The goal of opioid use disorder treatment is not to get people to stop using opioids. The goal is to keep people from dying. To keep people from dying. That's the goal. So a little note about language here. I prefer the term opioid agonist therapy, or OAT, because it's precise and it says what we mean. An agonist is, if you think about a key and a lock, an agonist goes into the receptor in the brain and turns it on. That's what agonist means. An antagonist is the opposite of that. An antagonist is like shoving gum in the lock so that it cannot be turned. And it's really important to note that methadone and buprenorphine are agonist medications. They have a really strong binding capacity, so they're able to grab onto that lock and turn it on and stay in there. We know that the results for studies on buprenorphine show slightly better results for pregnancy outcomes. It's hard to tell whether that's related to the drug or whether that's related to access to buprenorphine, which is getting better in a lot of places, like Seattle, shout out. But most of the studies that we're doing, people are accessing buprenorphine from their primary care provider in their local pharmacy. They're getting weeks or months of supply at one time, and they're not having to do a lot of the really onerous requirements that come with getting treatment at a methadone clinic, such as showing up every single day or having to wait in line outside and be exposed to the elements and the public view. And so oftentimes people who are able to access buprenorphine have a lot more positive social determinants of health than people who access methadone. So it's another one of those, is it the drug or is it the context questions? Now, the reason I don't like medications for opioid use disorder when we're talking about pregnant people is because that's all of the medications that are used for opioid use disorder, including naltrexone, which is an antagonist. Oh, I forgot. Let me talk about naltrexone first, and then we'll go back. So naltrexone is available as a pill that you can take as needed or every day. It's also available as an injection called Vivitrol, or I think there's a couple other ones on the market now too, and that lasts about a month. So all of the studies that are cited on this slide were done in pregnant people, but these results are pretty comparable to what we see in the general population. I don't want to talk Vivitrol down too much because for some people it works and it's life-saving, and that is awesome. However, for most people, it's less likely to be effective. We see a lot of patient dropout because it's just not a good treatment for a lot of people. Some people report that not only does it blunt the pleasure that they receive from opioids, but it blunts all pleasure. It makes it feel like it's hard for them to connect and bond with other people, and they don't feel like they have any joy in their life when they're on naltrexone. And that's significant because harm reduction isn't just about reducing harms, it's about promoting joy and wellness. We also see an increased risk of death with blocker medications like naltrexone, and that is partly based on the decreased tolerance. So when you're taking a blocker medication, the longer you go without opioids, the more your tolerance drops. However, with naltrexone, it kind of artificially keeps your tolerance way high because it's blocking those receptors. So what we see is people trying to overcome the naltrexone blockade of the receptors by taking really massive amounts of opioids in order to kick the naltrexone out of that lock, pick the gum out, and put in the key. So we also see people who stop taking this medication, the naltrexone gets out of your system kind of gradually. So you might have to take a really massive dose to feel anything this week, but next week that's enough to kill you. And so this creates a really dangerous and risky environment for overdose death. Another downside of naltrexone treatment is that you have to detox first, which especially during pregnancy is really stressful on the person. Also on the pregnancy, but hey, let's talk about pregnant people as if they matter too. Pregnancy is a super stressful time, and adding this other stress on top of everything, trying to access prenatal care and make sure that you have space for the baby and supplies. There's just a lot going on during pregnancy. So the gold standard remains methadone and buprenorphine. Despite all this, the fact that naltrexone is not an opioid, it's not a controlled substance, and there are no infant effects and no infant withdrawal, it's going to be really attractive to a lot of our patients who are worried about those harms that we're trying to reduce related to criminalization, surveillance, and the family punishment and regulation system, also known as child welfare. So despite all that, a lot of people still might want this treatment. So the summary is, if somebody is stable on naltrexone before they become pregnant, it is safe to continue, but it's not recommended to start during pregnancy. It should be a last resort and only offered if the patient really chooses it and is highly motivated and is fully aware of all of the risks. If you do start a patient on naltrexone during pregnancy, make sure you're checking in with them often, every day or two in the beginning, because they may really, really want this treatment and really, really be motivated to do it for their baby. But once they start, they might start having a lot of those side effects that we talked about. It might not be working for them. They might feel like they're at risk for relapse. Another issue with using naltrexone during pregnancy is it blocks all opioids, including anesthesia medications like epidurals and spinals for childbirth. So there is a protocol out of UCSF that I believe I have permission to share if anybody is interested. And basically it says at about 36 weeks, stop the treatment to give the naltrexone plenty of time to flush out of the system before it's time to deliver. If you have a birth that happens unexpectedly early, you're going to need massive doses of anesthesia medications, and it's just going to put the whole birth at a higher risk level. So it's best to transition to a different medication or stop the naltrexone treatment well before the birth. I think if you're having twins, then maybe even at 30 or 32 weeks, you should stop the naltrexone because the twins are much more likely to be delivered early. So that's also something to think about with this medication. I know there are a handful of providers on this call. Hello. Please become a buprenorphine provider. It's pretty simple. There's an application. You can treat up to 100 patients in the first year, and then after that, you can apply for an increase. Most of the programs are free. For physicians, it's 8 hours, and for midwives, PAs, NPs, and folks like that, it is 24 hours. CEs are awarded. You have to do CEs anyway. You might as well just do these ones, and then you can start increasing access to buprenorphine in your community. There also, as of last year, there's an alternative application which you can treat up to 30 patients without doing any of those training programs. However, if your plan is eventually to get the regular waiver, this time won't count towards your first year of that standard waiver. So there's the website is there. I believe that's going to be included in the slides. At the end, there should be a slide with links. And if not, it's pretty easy to find. You go to samhsa.gov and just type in search for BUP waiver, and you'll be able to find it. So I want to talk a little bit about contamination and fentanyl, and I'm just going to leave this up on the screen for a little bit. There is no risk of overdose from touching fentanyl or being near it. There is no risk of overdose from touching fentanyl or being near it at all. Fentanyl does not absorb through the skin. You've probably heard of fentanyl patches. That's a special formulation that allows it to absorb through the skin. I've gotten fentanyl on my skin a lot of times because we're always having to waste the rest of the epidural syringe. It's like this big 60 ml syringe filled with fentanyl, and you have to just jam that plunger down and put it into your drug waste bin or the sink or whatever. And it splashes and it gets on your skin, and you rinse it off and you go about your day, and it is not a big deal. So reports of overdose from, the nice way to say it is first responders, but we know that this is not paramedics. Paramedics understand how drugs work. This is mostly police officers. There is no possible way that they are overdosing from fentanyl in the ways that these reports are claiming. Fentanyl powder does not aerosolize well, and it's not possible to accidentally inhale enough to have any effect, let alone an overdose. The reports that we're getting of these supposed overdoses they're reporting symptoms that are the exact opposite of an opioid overdose. In opioid overdose, you get sleepy, you nod, your breathing slows down and stops, and that's how death occurs. Most of these police officers seem to be having panic attacks because they're reporting fast breathing, and their eyes are wide and they're feeling stress. which is the opposite of what an opioid overdose is. So I've included a few references on the slide. These are mostly references for training programs aimed at police officers, because while it might be kind of fun to giggle at these people, what they're experiencing is real. They're experiencing victimization at the hands of the war on drugs. They're experiencing a misinformation campaign, because if you're told that you can overdose from fentanyl by touching the handle of a shopping cart, you're going to be terrified. And it's our job as healthcare and harm reduction people to educate the public, and that includes our police officers. Another contaminant that you're going to be hearing a lot about in the coming years is called xylazine. This is a veterinary medication. It's not approved for human use because of really nasty side effects like hallucinations and distress, which I'm like, well, then why are we using it on kittens? But that's a whole other thing. Xylazine is not an opioid. The medication that it seems to most closely resemble is clonidine. So it's kind of one of those newer meds that works in mysterious ways, and we need to do more research on it. The one thing that is really troubling about xylazine contamination of the drug supply is these really severe skin ulcers that we're finding. And we're not finding them at the location of injection like we're accustomed to. They could be all over the body. We do also have inconsistent community perceptions. So some folks like xylazine. It gives legs to their opioids, makes it last longer, gives them a better high. Some folks do not want xylazine, but most people are not very good at discerning whether they are using xylazine or not. When we look at studies of used syringes of people, we find that a lot of people who think they are using xylazine are not, and a lot of people who think they're not using xylazine are. There are going to be some of those experts in communities that can tell the difference based on smell or the way it looks or the way it feels. But for the most part, most people are not very good at telling the difference quite yet. So we talked a little bit about why the dose is not predictive of the infant effects. And I'm going to, in the interest of time, keep going because I think we all wonder about that. So we're going to talk about tobacco and nicotine, and then we'll have a couple minutes for questions before we have to wrap up. Tobacco has some of the strongest evidence of harm of any of the substances on this list. Most of these harms are rather mild. Some of them can be more severe, but when we're talking about, for example, low birth weight, we're not talking about like 2-pound babies. We're talking about like 5 pounds instead of 6 pounds or something like that. So it can be significant, but it's not severe, I wouldn't say. So obviously, the best thing anybody who smokes cigarettes can do is quit for their own health, for their pregnancy, for their future, for their family. So we always recommend, as a first line, trying to quit smoking cigarettes. As a second line, we have lots and lots of approved pharmaceuticals, gum, patches, medications, things like that. There are inhalers for nicotine dependence. None of these have been approved for pregnancy by the FDA, but let's be real. There's only, I think, 2 or 3 medications that are approved by the FDA for pregnancy. So that shouldn't be a reason not to use these things. We do have a lot of decent studies of pregnant people using these methods with so-so success. Quitting smoking is one of the hardest substance uses to quit. And we see that when we look at data in pregnancy as well. All of the other drugs, whether they're illicit drugs or alcohol, there's a swift drop off when people find out that they're pregnant, but only about 50% of people who smoke cigarettes are able to stop during pregnancy. So any kind of harm reduction that we can do in this area is going to be beneficial. We'll talk a little bit about e-cigarettes, also known as vapes. Our public health messaging in this country is failing just horribly when we're talking about vapes. We certainly don't want our children to start using them, yes, but e-cigarettes are definitely safer for everyone than regular cigarettes. There is no controversy about that in the literature and in the data. We know that health and birth outcomes are improved for people that are able to quit cigarettes entirely and switch to vaping. There is a little bit more cloudiness in the data about people who are smoking less cigarettes with vaping and doing both simultaneously. However, it's really hard to capture cigarette quit information in a study that maybe only lasts a month or two. Most people who quit smoking kind of go back and forth for a long time before they're able to finally stop using cigarettes. And so even if somebody is trying to quit with a vape, but not successful, still having a cigarette here or there, I think that's something that should be encouraged, because maybe they don't quit during their pregnancy, but maybe they're able to quit after. Any chance that they're going to be able to quit is something that should be encouraged. So I want to end with this idea that a lot of times healthcare providers are like, oh, we don't know how to do harm reduction. Yes, you do. You do it with cigarettes every day. You absolutely do. When somebody smokes cigarettes during pregnancy or not, we encourage them to quit. We offer them supports, medications, treatments, counseling, whatever they need. And we continue to work with them, even if they're unable or don't want to quit. So why can't we do that with other substances? That's what works. That's what we know works. We need to apply this logic to all drug use and not just cigarettes. And I will open it up for questions there. We have just a couple minutes. Reagan, what questions came up in the chat, if any?
Okay, I think right now in the chat we have a lot of folks talking. The fentanyl conversation really kicked off a lot because folks were excited to hear you say that you can't overdose by touching fentanyl or being in the same room as fentanyl, and folks are talking about experiences they've had in their own areas. If people want to, if anyone has a direct question, feel free to put it right in the chat. And I'll call some out for Joelle to answer in the last few minutes before we close. I'm seeing someone say they want to know about cannabis, and someone mentioned methamphetamines. I can send out, Joelle actually worked on an incredible resource, a toolkit along with the National Harm Reduction Coalition that talks about harm reduction for all of these other sorts of drugs. So when I send out the recording and the slides, I'll attach that PDF to the email as well so folks can have it.
And Mandy Sladkey in the chat there, she worked on that resource as well. I will just mention a couple things about amphetamines, since it seems like that might be a theme in there. Firstly, there is no withdrawal from methamphetamine or cocaine for adults or for babies. What we see is more like a hangover. So anybody that uses large amounts of these substances is just going to feel crappy the next day. And that's not related to their tolerance or dependence. That's just how these things work, kind of like a hangover from alcohol. What we don't see is that withdrawal. So I like to use alcohol as an example because most of us have experienced a hangover, but most of us have not experienced alcohol withdrawal, which is recognized as a separate phenomenon. And so I want to just drive that home because a lot of folks are expecting babies exposed to stimulants to have withdrawal, and they just don't. There is no withdrawal from stimulants in adults or children. Meds for alcohol. So there are a handful of meds for alcohol. None of them have any good data in pregnancy that I have found. So I can't really speak to that very well. I'm sorry, Stephanie. They're probably safer than continuing to drink during pregnancy, but just related to the nature of how hard it is to ethically design a study around pregnancy and substance exposure, like we can't get that gold standard randomized controlled trial. So it's really hard to get high quality data around things like medications for alcohol use. But we do know naltrexone is safe, and that can be used for alcohol as well. There's a question about what can people do for harm reduction for drinking. Definitely nutrition is a big part of that. You can make sure that you eat healthy foods before you start drinking in the day. Take your prenatal vitamins, especially those B vitamins. B vitamins are associated with brain and spinal cord growth, and they are also one of the things that alcohol consumption reduces our absorption of. So especially B vitamins can be helpful for alcohol and pregnancy. There are no links to developmental problems with stimulants like methamphetamine. No. How do we keep people using drugs engaged in prenatal care? Come back next week. We're going to be talking about that a lot. That's the entire focus of our talk next week. But if you want the Cliffs Notes version, be nice to them. Ask them what they need. There is a Harm Reduction Works Facebook group. I think they meet on Mondays that focuses on pregnancy and parenting. There's probably a handful of people in here that are aware of Harm Reduction Works. Just search Harm Reduction Works. I think we're a little bit over. How are we doing on time, Reagan?
We are just slightly 2 minutes over. So
okay.
But I think that's okay. For folks who still have questions, as Joelle mentioned, we will be back next week at 6 p.m. To talk about trauma-informed care for pregnant people who use substances. And then in 2 weeks, we'll be back with a panel of clinicians, advocates, and attorneys to talk about how mandated reporting laws induce a lot of fear and stigma and can harm prenatal and postpartum outcomes. So very excited to see you all next week. I'm gonna sign off now. Bye y'all, thank you for coming.
Bye everybody, feel free to email me. I love to hear from folks.